Good afternoon. Welcome to the CCR by Department of Psychiatry and NDDDC. Today we are presenting two cases of opioid dependence in women. Opioid use in women is relatively uncommon. Now, as such, substance use disorders are uncommon in women compared to men. Here we are presenting these two cases and with special focus on the complexities in the etiogenesis of the problem. I'll request Dr. Atul Ambekar to take over.
Good afternoon, everyone. So, across all the time periods and across various cultures, use of psychoactive substance has been predominantly a male phenomena. Consequently, a very small proportion of people who use various psychoactive substances are women, and hence, a proportion of patients who are women substance users or suffering from substance use disorders, they are even fewer. At our own center, NDDTC, a very small minority of patients are actually women. And this is true across all treatment settings. All addiction treatment settings treat women with substance use disorders as a special demographic group, special population. But even though this group is smaller in size, the complexities associated with these patients in terms of psychosocial issues or even some of the biological issues, they can be very challenging. So today we are our team led by Dr. Piali Mandal, additional professor, and Dr. Kamini Verma, our DM addiction psychiatry resident. We are presenting two cases of opioid dependence with slightly diverse profile, some commonalities and some diversities in terms of the complexities which they bring for management. So I'll request Dr. Piali Mandal to begin the presentation, please. Thank you.
Sir. So traditionally, substance use by female is actually frowned upon across cultures, and it's considered it's a male phenomena. Until recently, research of substance use disorders suffered a lack of data on gender diversity. However, in late 1970s, the biopsychosocial differences in the pattern of substance use between men and women being gradually recognized. From whatever epidemiological evidence we have available, from that what we can gather is women are less likely to use substance compared to their male counterpart. However, it is present across age groups, and there could be regional variation. There could be variation there will be cultural variation in the variation, and depending upon that, there could be variation in the prevalence and types of drugs used by women. However, there is one theme which cuts across the type of drugs or the across religion, across culture is the theme of stigma. Stigma is experienced much more frequently by women substance user. For them, it is a double stigma for being woman and for being a substance user. It is a difficult to pick population through traditional survey methods. Treatment seeking is definitely poorer than their male counterparts. At our center, the female hardly constitute about 2% of the total treatment seekers. Now I will invite Dr. Kamini Verma, our DM resident, to present two cases from Women Clinic.
Thank you, ma'am. Good afternoon, everyone. So today I'll be presenting two cases of women who are using opioids and see how it complicates and affects various domains of their life. The first case is of an 18-year-old unmarried female belonging to Muslim nuclear family of middle socio-economic status, studied till class 9th, resident of Meerut. The chief complaints which she presented with were capsule spasmoproxivone use for last 2 years, PD use for last 1.5 years, and tablet alprazolam use for last 1 year. Patient was free of any psychoactive substance and was maintaining well till 16 years of age. She tried capsule spasmoproxivone plus out of curiosity in company of her best friend for the first time. This capsule consists of tablet tramadol, 50 mg, paracetamol and dicyclomine. As we can see from the figure, her use rapidly escalated from using 4 capsules on day 1 to at least around 16 capsules at the end of the week. And within a week, she also reported of having intense craving, and within 2 weeks, she started to experience withdrawals in the form of muscle ache and watering from eyes and nose. After starting substance, she also stopped studying after class 9. Patient was mostly buying these tablets from a nearby pharmacy without any prescription. Within a period of 5 months, her use increased to around 4 strips of spasmoproximon. Thereafter, she started to have complaints of abdominal discomfort and constipations. So, one of her friends suggested that she should use BD to relieve these symptoms. She also started using BD on a daily basis, and this habit was also considered cool among her friends. After a period of 1 year, her mother noticed her capsule use. Mother took her to a private hospital where patient was prescribed tablet tramadol 50 milligram and tablet alprazolam zero point 0.5 milligram. Patient started taking more tablets than what she was prescribed, and within a week, her use increased to around 3 strips. Her use of alprazolam also increased to around 8 tablets in a period of 1 month. She reported a sense of high after using tablet alprazolam, and she kept on increasing the tablets around 1 to 2 tablets every third fourth day. Whenever patient would have altercation with mother, that will lead to anger outburst, and she will take more tablets than what is her usual dose, around 24 to 30 tablets. That led to having seizures in this patient. These episodes were only related with overdose of tramadol, and they were not related with alprazolam use. When patient will have altercation with mother, or when her demands for money are not met, patients will sometimes cut her wrist. Mostly this will be superficial cut, would not require any hospitalization, and patient denies any suicidal ideation. She will put the pictures of this cut on Instagram or her WhatsApp status. There would also be symptoms of emotional instability and threatening behavior. At the time when patient presented to us, she was using tablet tramadol and tablet alprazolam, around 30 tablets per day. If you look at the life chart of this patient started using substance at 16 years of age, which is an early onset of substance use. And she was using multiple substances, opioids, benzodiazepines, and tobacco. And there were personality factors also in the background. The use of substances complicated many areas of patient's life, like in physical domain, she had weight loss, seizure, weakness. In psychological, there was remorse, there were conflicts with family members. She also dropped out of this school. Looking at the family history, patient is first in order of 2 siblings. Patient's father does not stay with them. He works in Saudi Arabia. Mother stays with them. She is a homemaker, and younger brother studies in class 8. There is no history of any substance use or psychiatric illness in the family. Systematic examination was within normal limit. There were 2 healed hyperpigmented cut marks of 4 centimeter on the left forearm. And in mental state examination, rapport was established. There were ideas of remorse in thought content, and mental state function was within normal limit. She had a fair motivation. Based on the history, according to ICD-10, we made a diagnosis of opioid dependent syndrome, sedative and hypnotic dependent syndrome, and tobacco dependent syndrome. Patient was managed in an inpatient setting for a period of 2 weeks, where investigations were done which came within normal limit. Neurological assessment for seizures was done, and personality assessment was done. Looking at the pharmacological management of all the substances, for the management of opioid dependence, patient was detoxified on tablet buprenorphine, which is a partial opioid agonist, and then followed by an antagonist management with tablet naltrexone 50 milligram. For management of benzodiazepine dependence, a slow taper of diazepam was done, and for management of nicotine dependence, patient was started on nicotine replacement therapy. For long term, the plan was to continue the patient on antagonist management of tablet naltrexone, regular follow-up, and retaining the patient in treatment, doing relapse prevention therapy, and addressing the specific issues, the specific interpersonal issues with mother, and intervening. Coming to the second case, she is a 36-year-old divorced female, not formally educated, working as a sex worker, belonging to Hindu nuclear family of lower socio-economic status, living alone in a rented accommodation at Nangloi. The chief complaints were tobacco use for last 24 years, alcohol use for last 24 years, daily use for last 10 years, and occasional use for the last 8 years. Tablet alprazolam use for last 16 years, and injection buprenorphine use for last 8 years. So patient was also free of any psychoactive substance till 12 years of age. At that time, she was introduced to cigarettes by some of her friends in the park, and she gradually increased the dose. During the same time, patient was also introduced to beer by one of her friends, and that time she started drinking occasionally. She got married at the age of 14 years. At 15 years of age, she has history of intrauterine death, and at 17 years she gave birth to her daughter. She continued using alcohol during her pregnancy also, as she was not aware of the harms associated with it. Patient started working as a commercial sex worker at the age of 18 years. Due to the financial reasons, patient husband was unemployed and he was not providing for the household expenses. After starting working as a sex worker, patient's consumption of alcohol increased. Patient started to drink daily around 180 ml of IMFL every day, and she would mostly drink with her clients. During the same time, she was also introduced to tablet alprazolam 0.5 milligram, and she gradually increased the dose to around 7 to 8 tablets at night, and she started experiencing withdrawals. Patient continued her alcohol use in the afternoon time and her alprazolam tablet use in the night time. Eventually, husband got to know about her job. He got separated, and patient also stopped working as a female sex worker. He started running a tea stall. There, patient met a person who was using drugs, and she started living with him. He introduced patient to the first time to the injecting drug route. When patient first tried buprenorphine and phenarmine, she felt a sense of euphoria, so she started injecting daily. Patient was unaware of the risks associated with this behavior, so there was frequent chances of reuse and sharing of needles by the patient. Over a period of 3-4 months, patient's dose increased to around 3 to 4 ampoules of morphine per day, and to sustain that injection drug use, she again had to restart working as a commercial sex worker. Another risk factor for the patient was unprotected sex. She continued to use tablet alprazolam, 6 to 8 tablets, but once she started using injecting drug use, her use of alcohol decreased. At the age of 31 years, patient partner at that time left her. She continued to work as a sex worker, and her injection use also continued to around 4 to 5 ampoules per day. Looking at the complications in these patients, physically there was weight loss, there was weakness, there's multiple thrombosed vein in the patient due to her continuous injecting, and there's a history of HIV also. She was diagnosed in 2017. At that time, she was enrolled in an hospital, but due to fight with the staff, patient did not continue her ART treatment. Her current partner and daughter were also unaware of the patient's HIV status. Psychologically, there was stigma, remorse, there was frequent altercations in family members, and patient was not working. Patient sought treatment first time in the year 2016, where she was admitted in our center for a period of 2 weeks. She was discharged on naltrexone, but soon after that, patient relapsed and did not continue in the treatment. If we look at the reasons why for the current treatment seeking of the patient, the main reason was loss of job during lockdown and the financial constraints which led to treatment seeking. Apart from that, there were some other psychosocial factors as well, like her partner was not approving of her injection use and she wanted to take part in her daughter's pregnancy. In looking at the family history, there was a lot of childhood adversities in patient. Patient's father left when patient was just 4 years of age. He was also a regular user of alcohol, and there would be incidences of domestic violence under intoxication. Her mother, her elder sister and her younger sister, all of them worked as a commercial sex worker, and there was history of teenage marriage in all the sisters. Her younger sister, who was working, she died of suicide by hanging at the age of 28 years when one of her clients left her. There was no any other history of psychiatric illness or substance use. Looking at the general physical examination was within normal limit. There were multiple recent injection marks and thrombosed vein on bilateral arms. In mental status examination, it was difficult to establish rapport with the patient. Patient was guarded about her job, her substance use initially, but a working relationship was established. There were ideas of remorse in her thought content, and higher mental functions were within normal limit. Based on that, according to ICD-10, we made a diagnosis of opioid dependence syndrome, alcohol dependence syndrome, and sedative and hypnotic dependence syndrome. The goals of treatment for this patient was retaining her in treatment, starting her on agonist maintenance treatment, reintegrating her with the ART services, and improving her psychosocial functioning. All the investigations were done which came within normal limit except for HIV positivity. For management of opioids, patient was stabilized on 10 mg of sublingual buprenorphine, and for management of benzodiazepine, slow taper of diazepam was done. In non-pharmacological management, psychoeducation of the patient was done about the treatment, the nature of illness, the compliance to treatments, and issues regarding her stigma and HIV was addressed. And also importance of using barrier contraceptive in this patient was addressed because she was working in a high-risk job. Apart from that, motivational enhancement and relapse prevention was done. I would like to invite Dr. Pyali ma'am now to discuss more challenges associated with these patients. Thank you.
Cases presented by Dr. Kamini had they had some few commonalities in respect to the kind of substances they have used, the reason for initiation, then the significant physical complications in both the cases. However, there are very many differences in the cases. Like the first case belonged to a relatively stable middle socioeconomic status Muslim nuclear family, whereas the second case belonged to a lower socioeconomic status and a broken family. There were differences in terms of childhood adverse experiences, occupation, high risk behaviors like injecting presence of injecting drug use, high risk behavior in the second case. Fast progression in the drug use career was evidently observed in evident in the first case. There was difference in the treatment seeking behavior and social support, and considering these differences, the long term treatment also differed. So, in the first case, we see a very fast progression. This phenomena is called telescoping. This term is used to describe an accelerated progression from initiation of a substance use to the onset of dependence. Because of this reason, the woman often, when they present in the clinical setting, they present in a more disheveled state, and this phenomena has been observed across substances. Like in the first case, you see like the patient developed the dependence on alprazolam and dependence on tramadol within months of starting it. And then in the second case, we see that patient started alcohol use in an occasional pattern at about 12 years of age. Like she took around 8 to 10 years to develop dependence on alcohol. That is the usual pattern of time gap which persons take to develop dependence, and that was faster in the first case. In the second case, we have, as we have been pointed out, there are multiple adversities experienced since childhood. There was intimate partner violence, early teenage marriage, teenage pregnancies, subsequent engagement in high-risk jobs like female sex work. We could see a very close association with the kind of occupation she was involved in and drug use. Like before the initiation of female sex work, she was hardly using alcohol occasionally. But after that, after starting female sex work, she was into alcohol use almost in a regular pattern and developed dependence soon. There was introduction of injecting drug use through a partner. She returned to her sex work when she in order to sustain her drug use. And there are high risk behaviors also associated, like unprotected sex, sharing of needles and syringes. This is one case which is exceptional in a way. It has got very long duration of untreated drug use. She started her opioid use with injecting drug use directly. She was HIV positive, and she was definitely poor. There was poor compliance to treatment as well. With this case, we had lot of challenges to manage. The first challenge was to establish rapport with her, because she was very secretive. She never wanted to divulge any information to even to the whole clinical team. She was very sure to just to divulge the information to the resident SR who was looking after her. We took utmost care to keep the information confidential. We did not divulge any information to the staff, even to her daughter. She did not want to divulge the information to her daughter because she was afraid that she might be rejected by the family. There was a lot of stigma associated with related to HIV, and possibly she was also afraid of losing clients, leading to further financial burden if people come to know about her HIV status. So if we try to see these two cases in the light of epidemiological evidence which is available from India regarding treatment-seeking women population, there are quite common features in them. Like both of them started their substance use career with they presented in the OPD with opioid use. However, in the community, The tobacco users outnumber alcohol or prescription drug user women. The reason for initiation, although in these two cases were different, they started because they wanted to experiment with the drugs. However, in many treatment centers, the women are often found to present with iatrogenic causes of initiation of substance use. The women cases are often commonly associated with comorbid psychiatric illness, as we see in the first case. That patient had multiple personality issues, which we tried to manage, tried to address in our management. In her thesis by Dr. Kamini, she could demonstrate that there was much more self stigma among women drug users compared to their male counterpart, and more interestingly, the stigma among family members who are associated with women substance users were much more than the family members of male substance users. The second case also possibly represent a typical case of female injecting drug user, as depicted in the studies from northeastern part of India. There are multiple barriers which have been pointed out in the literature as far as treatment seeking by women is concerned. Some of them are societal, some of them are structural, like the location, geographical location of the center, or the unfriendly treatment services, cost of treatment, stigma, lack of family support. Many of them are evident in these two cases. And there is also systemic barrier in terms of underrepresentation of women in policy development and resource allocation. At NDDTC, we have initiated a women's clinic in 2015. It is the separate clinic dedicated only for women and also a gender minority population. So far, we have been able to register about 600 women. We have been collaborating with other departments and NGOs to work with women, publishing clinic-based papers, and also when we were with a vision to expand our services through exclusive female ward. Thank you.
Thank you very much, Dr. Piani. So, questions, observations, or comments, if any? As both these cases show us, it's a very different population. It may be a very difficult and challenging population also. Challenges are often compounded by the services or the infrastructure, which may not be very suitable, very responsive to the needs of female patients. Imagine our NDDTC ward full of 50 men patients and with only one female patient with an attendant in the form of pregnant daughter with her. And this highlights the need for exclusive kind of infrastructural support for this population. Sir. Yes, sir, absolutely. Sir, one is that as we showed in the opening remarks also, that substance use predominantly is a male phenomena. So, number of women who use substance proportionately are much lower than men. But even though among the women substance use disorders who are there in the community, the treatment seeking is even lower because of stigma and various other, because of non-suitable services. Yes. So, the epidemiological data which we have collected, it suggests that there is substantial difference, but still, if the services are responsive, then you certainly get more patients. For instance, the number of female patients that we have started getting since we have our women clinic, it has gone up considerably. So once services are available.
I had gone to Dharan for a month, and one day I received a call. Basically, that was more for the teaching program, the UG's teaching program, because the earlier psychiatrist had left. The earlier faculty member had suddenly left, and they requested me to go there. And one day I received a call that one 60 years old lady is having some disorganized behavior, and she was admitted for cataract surgery. And I went and saw, and I came to know that she had developed delirium, and it was because of the alcohol withdrawal. So there are many regional different, and it was a great surprise for me. But later I came to know that in that area the alcohol use was common in women. Same way in Northeast alcohol use is common, and so there are regional differences. Then in certain tribal populations in different parts of the country, maybe Jharkhand and some other areas, the alcohol use is common. Then opioid, as you said, in women in some areas of Punjab. So uh, tobacco is very common in UP and maybe Bihar also and some other areas also. So there would be differences in Punjab or say Haryana or other places. Substance use may not. It's often in women. It's frowned upon also. So trends are changing. Like
Yes,
we
sir.
had a national survey which covered almost all districts of the country, and which had nearly 500,000 population. So there also the Dr. Atul was the chief investigator for that. So there are major differences. Definitely regional differences. There are certain regions, regional differences. Northeast, the substance use may have been common, but in women, but overall, it's uncommon. Like we have depression and anxiety disorder more. When we talk about the prevalence of mental disorders in across gender, the total prevalence and incidence is nearly equal. But in women, depression and depression, anxiety disorder are more common, whereas the substance use disorders, alcohol, is more common in men. So that takes over. So that's the difference.
Yes. Kelly wants to add
And
something.
since this is a double stigma for women and it's a difficult population, so we often have to in the general household service they are not often picked up. So we have to go for other techniques like snowball techniques and other things.
Have used naltrexone. In benzodiazepine, you don't use any like flumazenil.
For benzodiazepine, heavy benzodiazepine use or dependence, we have replaced the she was using the patient was using alprazolam, which is a short-acting benzodiazepine. So we replaced it with long-term benzodiazepine like diazepam. As per recommendation of various guidelines, we do that, and it often takes months, sometimes a year, to actually taper it down to zero. So that is the standard guideline for treating benzodiazepine dependence. Flumazenil is generally not recommended. So.
Any more?
Right.
Very good question.
It does pose a very important legal and ethical dilemma, but we can go into a long debate on this particular issue. The law on this particular issue is very clear. We are not supposed to notify or disclose any patient's real or perceived HIV status without their explicit consent. We can engage in all possible of counseling with the patient and give them psychoeducation and whatnot. But we are not supposed to do this in the larger public good. Yes, there is a question, I suppose.
Uh, yeah, we did LFT and other routine tests. All were normal, fortunately, in that patient.